Morning. This is House Healthcare, January 28th. And we are starting with a walkthrough of H585. We're not going to walk through the whole bill. This bill, we're going to sort of take in sections, and we're going to walk through right now the sections that pertain to some things together, which are correlated. So Jen, if you want to come up. We don't have the bill posted on our committee page today.
Good morning, Jen Carvey from the Office of Legislative Counsel. So I am going to put the bill up on the screen and then we're going to jump to, I think, section 3 is where we're starting. So I think what we're doing right now is sections 3 through 9, which are kind of expanding access to different types of plans. That is what I plan to walk through unless I get a whistle from the commissioner that that is not what they were prepared to talk about this morning. So I'll put that language up on the screen. And so I will take us back up to the beginning just for a moment to show that this is H585. This is an act relating to health insurance reforms. And then we're going to go to page 10. Which is where we start with limited age rating. So there are a number of different types of provisions in this bill. The grouping that we're going to be looking at first this morning is relating to some expansion of plan offerings and some changes to plan rating, the premium rating. And so sections 3 through 6 kind of go together. We get to the meat of it kind of in section 6 and kind of in language you can't actually see that I will also put up. You need a minute.
Sorry,
It's okay. Just wanted to make sure everybody was set before we jump into the language. So we'll look at sections 3 through 6, but then we may take a little jump over to existing statute to see kind of what this means. So the general idea behind sections 3 through 6 is to implement some limited age rating, which would allow people to be charged different premiums based on their age, but within a fairly small margin. So sections 3, 4, and 5 are just because they come first in the statute order, are just taking out a little tiny reference to subdivision B in 33 VSA section 11 F2. So that's what we're going to look at in a minute is 33 VSA section 11 F2. But under existing law, these are statutes relating to hospital service corporations. Then you'll see medical service corporations and health maintenance organizations, which are different health insurance types or entities that offer health insurance in this state. And
I don't know these terms. I mean, I don't know the different terms of these different types of things. And I didn't know if we could get some definitions, maybe not now, but.
Yeah, and I might let DFR, since they regulate the different insurance types, tell you.
That would be
yes. And we're going to look some more at some other governments for these corporations as well. But these are just different insurance
models
they're different insurers. So they're insurers with different kind of structures.
Okay.
So some of them are nonprofit, and to qualify for the nonprofit status, certain things that the insurers have to file annually with the Department of Financial Regulation have to do with certifying that they operate on a nonprofit basis for purposes of providing plans, health insurance plans to people in this state without discrimination based on, and then there's a list, age, gender, geographic area, industry, and medical history, except as allowed by statute. So that's what we're going to look at. And the B part is more limited and directed more at DFR. So now we're just saying F2 generally, except is allowed by F2 generally. Section 4 does the same thing. It just says if you're nonprofit, you have to certify that you're offering plans to people without discriminating except as allowed. And so removing that reference to subdivision B, F2B, and then same thing for nonprofit health maintenance organizations as well. So let's look at what that statute says, and then we'll see what we're directing DFR to do in the next section. So I have this queued up here. Put it up on the screen. All right, so again, for a little orientation purposes, here we are in Title 33. You can say this, yes, Title 33, Chapter 18, Subchapter 1, Vermont Health Benefit Exchange. This is where we talk about the health plans for individuals and small groups. And some changes were made last year when the plans or the markets were unmerged. So you'll see certain things took effect as of January 1st, 2026. So that's where we are now. So we'll go to that version. It's just the separating the individual and small. Okay, so under existing law, a registered carrier, so a carrier who's offering plans through the exchange, shall use a community rating method acceptable to the Commissioner of DFR for determining premiums for health benefit plans, and shall determine the premiums for the carrier's plans separately from the premiums used for its small group market plans. So that's how we separate them. Except as provided in subdivision 2, the following risk classification factors are prohibited from using in rating individuals. So you can't charge different premiums based on these items. Demographic rating, including age and gender rating. Geographic area rating, industry rating, medical underwriting and screening, experience rating, tier rating, or durational rating. But existing law allows the Commissioner of Financial Regulation by rule to adopt standards and a process to allow carriers to use one or more of these risk classifications in their community rating method, as long as the premium charge does not deviate above or below the community rate filed by the carrier by more than 20%, and further provided that it's never okay to allow medical underwriting and screening, and the Commissioner's rules must give due consideration to the need for affordability and accessibility of health insurance. What does this all mean? This means that under existing law, for the most part, plans are not allowed to use these factors in their rating. So for community rating, the way we do it now, we have basically pure community rating. So everybody pays the same amount for the same plan. In other states, it doesn't necessarily work that way. In Vermont, it does work that way currently. But this would allow the existing laws, but not necessarily the rules, allow some variation. And so what we're about to look at is directing DFR to use this authority to allow for some limited age rating. So of this whole list, just limited age ratings.
Val, you have a question?
Definition of community.
Community rating is when everybody in the same pool gets charged the same amount. That's the community for the plan.
So why do we need to do anything to this bill if the Commissioner already has the authority to do this?
Well, under existing law, those 3 sections we looked at the references to are really in this B part.
Okay.
So the existing rule says the plans have to certify that they are not doing any variation from pure community rating, except that the Commissioner's rules must allow a carrier to establish rewards, premium discounts, split benefits designs, rebates, or other sort of variations in return for someone participating in a health promotion or disease prevention program. So this is not about age rating. This is really about if you do some wellness stuff, you might get a reduced premium. So right now, that's the piece that the law points to say insurers certified annually to the Commissioner that you're not varying rating except as allowed for this wellness benefit. And so we're taking out the reference specifically to this B so that now it includes 2A and B. And C and D are also, I mean, some of these are not about varying premium, but just how the rules will work. So that's why this is in the bill. But to provide a bit more both context and limitation, because the law allows a 20% variation, the bill is allowing less than that.
And 20% variation in the cost of the health insurance plan.
In the price of the plan, right? So if you think of kind of the community rate as being neutral of the above and below. All right, I'm pulling up the wrong thing here.
Well, actually,
Right
can I
now,
ask about that? So above and below. So if you have a neutral, can one be 20% higher than the neutral and the other 20% lower than the neutral? Or is it that they cannot be more than 20% apart from each other?
well, it says, provided the premium, the existing statute says, provided the premium charge shall not deviate above or below the community rate filed by the carrier by more than 20%. So that, my reading is up to 20% more, up to 20% less. That's the existing statute. So here is the language of, again, of the bill. So aside from taking out that reference to subdivision 2B, section 6 directs the Department of Financial Regulation to review and amend its rules and guidance as needed to allow health insurers to use age classifications in the premiums charged for their individual and small group plans starting in the 2028 plan year, provided that the premium charged to any cohort, so any group within that community group, shall not deviate by more than 5% above or below the community rate filed by the health insurer. So 5 up or 5 down.
So theoretically, I'm just throwing ages out here. Theoretically, a 27-year-old could pay 10% less than a 64-year-old.
I believe so, but I will defer to DFR to
They can, okay.
get into the
I'm just trying to figure
details.
out the deviate, like if they can't deviate 5% from each other or from up or down on the.
I read it as above or below the sort of the baseline is the community rate without any variations, but DFR is the one who implements this. And if we need to modify language to be clear about what's happening, we can do that. Sections 7 and 8 are around expanding access to association health plans. Association health plans are where a group of employers get together to buy insurance or to provide coverage to their collective employees. And a handful of years ago, Vermont made some pretty significant changes to association health plans. There used to be a lot of association health plans before the Affordable Care Act. They were significantly restricted under the Affordable Care Act as initially implemented. Under the first Trump administration, there was some expansion of ability to use association health plans. Vermont made a decision not to allow most of that. Then there was some litigation around the U.S. Department of Labor's rules that also put some limitations on the expanded nature available nationally. So these two sections would reopen Vermont to more association health plans. And what all of the details of that look like, I will let DFR tell you, because again, they regulate here. But under existing law, so this uses definitions that are consistent with federal definitions under ERISA, the Employee Retirement Income Security Act of 1974, and the U.S. Department of Labor's regulations and guidance. This strikes language in Vermont law requiring associations to have at least 100 people in them at the time of incorporation or formation, have been organized for a purpose other than obtaining insurance, have been in active existence for at least 1 year, have a constitution and bylaws providing for certain parameters around the association's activities. Specifying, just still striking through specifying the association will not be controlled by a health insurer. And specifying the factors that can be used as evidence to determine whether an association is operated by a health insurer. And so that's one piece. And then the other piece, we have a statute specifically on association health plans. And this would modify the definition of association health plan, take out existing language around a policy being issued to an association or other similar entity. And specifically for our purposes, striking out language saying no association health plan shall be issued, offered, or renewed in this state to any person other than an association that was formed or was eligible to have been formed under ERISA and the accompanying U.S. Department of Labor regulations that were in effect basically prior to 2017. And instead just saying a group that is eligible under the previous section is eligible. So the result of this is to reopen association health plans in this state. And again, I will let DFR give you the details.
So association health plans have to, under the ACA, do they have to have like comprehensive benefits?
I believe there are certain benefits that are applicable to large groups that apply, but not the benchmark plan that is applicable to individual and small.
Yeah. But they can't be like minimum essential coverage plans, or can they be?
That's a different term of art, so I wouldn't want to. I mean, can they be minimal coverage? I think there are certain required benefits, but they're not as comprehensive as what is in your individual and small group plan. And again, others may be better equipped to give you the specifics. Finally, section 9, finally for our purposes in this chunk, is expanding access to short-term limited duration plans. And at the same time that the Vermont legislature was working on association health plans and limiting access there, it was also placing limits on access to short-term limited duration health insurance. So under existing law, that term is defined as health insurance providing medical, hospital, or major medical expense benefits coverage under a contract, policy, or contract with a health insurer that has an expiration date specified in the policy or contract that is 3 months or less after the original effective date of the policy or contract. This is simply using the federal definition. Still requires anyone offering a short-term limited duration plan to get a certificate of authority from the commissioner. But under existing Vermont law, these plans are non-renewable, so they cannot be renewed. And a health insurer is prohibited from issuing one to any person if the issuance would result in that person being covered by a short-term limited duration health insurance coverage for more than 3 months in any 12-month period. And instead, this would simply say that a short-term limited duration policy or contract shall not have a longer duration than 12 months in total, taking into account any renewals or extensions that somebody could be covered for the 12 of the 12 months as opposed to 3 of the 12 months under existing law. And there are certain requirements around prominently displaying the limitations of this type of coverage in the policy or contract. That does not change. And the commissioner still has rulemaking authority to require certain things to be included in the plan and having advertising and other information submitted to the commissioner for the commissioner's approval. And I think we get into other types of sections. So I will stop you there and let DFR put color on what all those may be.
Thanks, Dan.
Yes, and I'll just be in the corner.
Morning, hi Sampson. Department of Financial Regulation. want to just start by saying 585 is a big bill. I think there's around 10 different distinct provisions. What Jen just walked through is kind of in a category of options or greater choices for Vermonters. And some of these are big changes philosophically and regulatorily. And we get here because, you know, the level of price, our demographic issues, it's in terms of how they impact price on the exchange, make it difficult for us in regulation to look at small businesses, to look at individuals who have gone uninsured and say, no, you may not look at that. You may not have that. When we're in a better situation as a market around affordability and cost of care, this regulatory approach that the legislature, administrations, and regulators have all been aligned on made some sense. And I'm going to say that in some cases that we'll talk about in this bill, we need to make some subtle changes, and in some cases, less than subtle changes. Starting with age rating. So I want to make sure I cover any definitional questions anyone has from Jen's walkthrough.
I didn't know the different types of insurance. So I started reading it last night.
Yeah, right.
So that was, but I don't know if I'm the only one or if there is a definition section, you know, of the different
Yeah.
plans.
So I think maybe that your question came up around association health plans.
Well, there was,
Sorry.
Please,
The
yeah.
nonprofit hospital.
Okay, sure.
yeah,
So a nonprofit hospital and a nonprofit medical service company is essentially Blue Cross Blue Shield of Vermont. They are licensed differently than a traditional insurance company. They are enabled specifically through statute and have some protections and tax exemptions because of that. So a carrier, commercial carrier like Cigna is licensed as a traditional insurance company. Technically, Blue Cross Blue Shield is a nonprofit hospital and medical service provider.
so there was a hospital service corporation described in the bill. And that was, I got a little stuck, right?
Yeah,
Each
that-
one.
I'm not certain, but I believe that's historic. Same thing, Blue Cross Blue Shield.
Okay. I wasn't sure what applied where.
Yeah.
Yeah.
Okay, so age rating. I submitted some written testimony and some exhibits. This is a deep and dense topic. And Joe Valenti, who I believe has joined me on screen here, our Director of Policy, has asked me to keep it to 4 minutes.
Good luck with that.
He was
So-
our committee.
But you do have an agenda, and I want to honor that agenda, but so it's hard for me to really get into this. But Jen went through what community rating is, which is those factors in law that were highlighted aren't factors in determining premium. Doesn't matter where you live, doesn't matter what your health history is, doesn't matter what your pre-existing conditions are, doesn't matter how old you are. Everyone gets the same rate. On the exchange right now, everyone gets the same rate. When you go shopping, it doesn't matter how old you are or where you live. That's community rating. We are not disrupting anything in that list of rating factors except for cracking the door open on age rating, on age. And there's several reasons for that we brought this forward. Age rating really came in, I think, in 1992, or sorry, the ban on age rating. I believe that statute. I'm not quite sure what happened before the Howard Dean reforms on health insurance, but I think it's like Act 110 of 1992. I believe really solidified, if not created, this framework of community rating. Back then, the median age in Vermont was approximately 34. I've put some numbers in my submission that I got from Vermont Department of Labor. Now, the median age, so 50% above, 50% below that age in Vermont, is a full 10 years older. And what does that mean for a community age rate? Well, when you combine that with the fact that there is an absolute linear, nationwide, actuarially shown correlation between your utilization and cost of care and age, That's recognized in the ACA. The Obamacare ACA allows 3-to-1 age rating, meaning your oldest cohort on qualified health plan state may allow premium 3 times that of the youngest cohort. In Vermont, everyone pays the same. So there is a direct relationship between need for healthcare services and cost to the insurance plan and age. Again, what we're proposing is, can we adjust that by 5%? It's a very subtle adjustment, and I think there's some opportunity to optimize and have some benefits to the risk pool because of that. Another fact, go ahead. Yeah.
I'm going to Leslie, but I'm unclear as how it changes anything.
That was sort of, what do you gain? Could you give an
What do you
example? What do you gain? What do we gain?
So
Like that
it's
change.
broadly understood that with this cost structure right now, the cost of health insurance in Vermont, that those, and we are losing folks because of extended tax credits. So who's most likely to drop insurance, and what is the impact on the pool when they drop insurance? So the answer is, if you ask me and a lot of professionals in this space, person most likely to no longer pay into the exchange is, again, more likely a younger, healthier person who, instead of paying $1,100 a month, now pays nothing. And instead of that $1,100 a month going into the pool, into the community pool, and only drawing out a couple doctor's visits for a cold every year, a couple $100 per year on a $12,000 per year premium, they're not even contributing. It's a balancing thing, a pool, right? The idea of community rating is everyone pays in and everyone takes out at the same amount, essentially, actuarially.
Because do we have any data on, people in the pool, their ages, who's not in the pool and what their
Yeah.
ages are?
So this is the Diva Health Map. This shows you.
It's on this thing.
This is a problem in terms of price. It's great that, and this is just reflective of our, nationwide, maybe globally, the baby boom, and other factors. This graph didn't look so age, obviously. This is, up to 64. At 65, you can go into Medicare. So the exchange is essentially up to 64. When I referenced 1992, when the median age was a full 10 years younger, approximately, this chart looked very different, which meant that a 20-something paying into a community-rated situation or market was, and I hate to use the term subsidy. Insurance is all about subsidy. It's what we do. When I back into Topper's car and have an accident and, I get $10,000 to fix his car, someone else is subsidizing it who didn't have an accident. So subsidy, I don't mean in a negative way or pejorative way as it's sometimes used, but because insurance, that's what insurance about. But the business of regulating insurance is to try to do a fair job of attaching cost of insurance to where that cost comes from.
I just want to, I want to further this because I don't think that answered my question.
Okay.
I
Yeah,
know the
you're right.
chart. I absolutely understand that there are more people who are on the older side in the QHP than younger. However, I'm talking about the missing. The people who aren't in here.
Yeah.
Do we have demographics of
Oh, people
the uninsured?
dropping out.
I'm thinking about life, and obviously everybody's life is a lot different. But I'm thinking of younger people have a tendency to work for employers. People who start their own businesses who would need to be in the qualified health in a QHP. They tend to be a little bit older, a little more life experience, not that, but I'm wondering, of the uninsured population, who do we think we're missing out of the QHP that is younger, that is not buying because of price? Because if we're gonna start messing with community rating, it seems to me we should have a handle on who we think we're enticing to come back into the market if we're going to dramatically, well, maybe not dramatically, 5%, we're going to increase the costs on another. I'm just trying to figure out who's missing from the market right now that we think we can entice back in.
And can I just add to that?
Yes.
Or who might drop off the market
Right.
if we do this?
Yeah.
And can I add that?
Yeah, so I wanted to get to Leslie's question.
Yeah, because it's all connected. It's like, if I understand right, if you said $11,000 a year for premium, did you say that?
I think some of the least expensive bronze plans for an individual would be about $1,000 a month, just over.
Okay, so say $12,000 a year, but
Yeah.
that 5% is about $600 a year. So you're dropping the premium, and if I'm understanding it right, by $600 if we institute age rating. Am I getting that right? How is that impactful in context of what Alyssa said?
Yeah, so I think lots of questions there. So who might I hope to? So we want to prevent younger, healthier people from opting out of insurance because that makes everyone's insurance costs go up because they are, in effect, helping keep rates down by keeping the pool relatively healthier. So I agree there, or that's my answer there. In terms of who would we like to attract back, we would like to attract back the same population we want to retain, which is folks who, and it's developing situation, right? Enhanced premium tax credits expired and are no longer available for a certain population on the exchange. And we're just getting updates from DIVA and insurers about how many folks are not re-enrolling. I don't have the data. I'm not sure if DIVA or the insurers would yet on any demographic information about that, but I'm sure it's available and can be forthcoming. So that's the answer there. Actuarially, part of the response, or part of what's instructive here is that if you look at the 2020, the QHP rate filings of last summer that are policies that are in effect now, the actuaries of both MVP and Blue Cross Blue Shield had to ask for a higher rate to incorporate the impact and the estimates of losing people because of the loss of subsidies. So that shows you that the math is there to show how everyone's rates go up when people go uninsured. And their models showed that those were the folks that would choose to go uninsured because of that cost sensitivity would be detrimental to the pool. So that what we're trying to do is stem that, reverse it. I would say that there's a potential, and this is what I've been working with insurance company actuaries to try to explore and would explore if this goes forward. Is there a way to optimize this? Meaning, given this population spread, is there a way to say for the older cohort, allowing an increase of 3% could actually reduce the younger cohorts by 6%, not 3%. So, I'm making up numbers here, but this is what I've asked some actuaries to look at. So that's one of the potential positive outcomes. Overall, that explains a big reason that I want to go here in terms of age rating. Another big reason is I think it's patently unfair the way we price right now. We have the other issue is that income goes up 2 to 3 times during this age continuum. So what we have is the equivalent of a flat tax, but even worse in that the folks pulling the most value out of the system as a cohort, statistically, are also earning the most money and paying the same premium.
I'm sorry, isn't that what insurance is?
Yeah, absolutely.
We all pay in,
Right.
hoping we never need it,
Yeah.
but eventually we're all going to need it. And everything you've paid in over the course of your lifetime, you then finally get back.
Right. And so the amount that someone who's in an older cohort now may have paid in when they were in their 20s, the amount of subsidy, if you will, pales in comparison to the amount of subsidy people in their 20s are paying now because the cost of care escalation and this demographic trend. So whatever that formula, and yes, that's what insurance is about. Insurance regulation is about fine tuning that. Okay, we don't expect everyone to pay for the reckless driving of young drivers. They pay a higher rate. But we don't, in some states, rate based on gender in auto insurance. You know, so states make up their minds about what's fair to have in cross subsidy and insurance and what isn't. You know, I don't force you to have flood insurance if you're not in a floodplain. So it's not as simple as like, hey, we all pay and everything. And well, it is that simple in health insurance. I'm saying, let's break that open a little bit to the benefit of what I believe the state needs to do, which is to make things a little bit better for young families in all areas of housing, insurance, taxes.
Did you have a question? Okay. I have Lori and then Leslie.
So curious if you'll have more analysis for us on what that 5% could look like in regards, like let's look at the premiums and the cost of insurance today.
Mhm.
Has DFR done an analysis to say, well, if this was in place and we had this 5% deviation, which I want to get your question answered on if it's really a 10%
Right.
deviation.
Right.
What it actually means dollar wise to a consumer of healthcare, both in the younger age and the older age. So what's the true value of this to Vermonters? There was some analysis done back in 2019 when this was brought to us. So even looking at that and updating it would be helpful because based on that analysis, we didn't make any change. I appreciate not just getting rid of it completely, which is what I
Right.
think 2018 was. But I'd love to see some more analysis and the actual value
Okay.
to Vermonters.
Yeah. And thank you for reminding me of the chair's question. The way it's worded, depending if we go forward with this, right? What I'd like to see is that no more than 5% increase for anyone. But as I said earlier, actuarially, if there's a retention factor or bringing people back or just the age difference in where the age banding is allowed to happen, I wouldn't want to limit that to, well, we go up 4%, but we're not allowed to go down 8%. So, but the way it's worded now is really deviation from what would be the community rate, which is the current system.
Do you envision that each of these are you envisioning maybe, you know, under 45, over 45, or are you thinking, you know, 18 to 26 has one? How many age ratings do you want to have?
So, you know, I think as was clear in the walkthrough, we have regulatory authority to do this up to 20%. This is a big deal. We wouldn't do it without this discussion and without hopefully your green light to do something. So our process for amending that reg would include a lot of actuarial work that's expensive and time consuming. I think we can answer questions like yours. But so I don't have the answer to that. But what I'm envisioning is keep it somewhat simple. Not some states have, you know, age bands very tightly with age, curve they call it, and that's in the materials as well, all the way up from, you know, 18 to 64. You know, when I initially started thinking about this, I noted from this age distribution that about half of the people on the exchange are over 35. And no, sorry, over 35 is 2 to 1 for that under 35. So just straight math without any additional retention or preventing additional loss. Straight math would mean that if you said over 35, you pay 4% more, means under 35, you pay 8% less. I believe it's that straight in terms of looking at today's prices and doing that. I'm not saying that's the proposal. The proposal would be driven by what works for carriers and what is least disruptive, and probably would need to have at least 3 categories to avoid a cliff. So that, you know, if a 40 was a break that you didn't go from, you know, -6 to +3, so +9 by having a birthday. So it would be smoother than that.
Leslie, did you have a question?
Just tagging on to what Lori was asking, do we know that this kind of, you know, 3%, 5%, sorry, changes behavior is it enough of an impact to change behavior?
I think part of that is answered by how actuaries modeled the loss of the enhanced premium tax credits. And the answer was yes. It changed behavior. It was a higher magnitude for sure. And that's one of the areas that the only way to really answer that is to get the actuaries to work.
So what I'm hearing you say, just to make sure I
Yeah.
understand, so the behavior that was changed was people dropped their insurance.
Correct.
Does it also change behavior to people to buy in with a 5% reduction?
Yeah, I would have to rely on actuaries to
But
accurately.
we're not.
I think logically thinking, yes. You're not going to know that, but
Because it's
that,
only $500 or $600 if I'm understanding it right. But I'm not sure I'm understanding. I just want to make sure I understand.
no, I think that is the scale we're talking about.
Yeah, compared to a
Right.
$12,000 yearly cost.
Correct.
It'll
Yeah.
now be 11,500.
Right.
So that maybe this will shed some light on it. Right now, we don't do anything. You can do 20%.
Correct.
Correct.
Through rule.
Yeah.
We'd have to amend our rules.
That, that.
Go ahead.
That was under community rating.
Under the current statute,
Right.
age is one of the community rating factors that the commissioner may issue. a-
Today, as we sit here, you can do 20%.
Well,
What you want to do is get away from the community rating so that you can split age groups and charge no more than 5%, not increase or decrease more than 5%.
it's the same flexibility. So the current statute says the commissioner can issue a rule that deviates from those community rating factors, of which one of which is age.
Yeah.
But by no more than 20%. What we want to do is not 20%. We want 5%. What I don't want to do is now forever limit myself to 5% by getting the legislature's endorsement of this plan. But if that's what happens, that's what happens. But it's the same idea. Ultimately, what we're trying to achieve is input and consensus that this makes sense for Vermont, that it's not just a rule coming out of DFR blindsiding the legislature and LCAR.
Use the actuaries to do that.
Right. So there's some to answer a lot of the important questions, we got to go through actuarial study and the rulemaking process before we start the rulemaking process. We got to know what we want to do. And we can't know exactly what we want to do and exactly what behavior, if any, is impacted by those amounts before we. So I can't tell you exactly how it would look. And that's why so many things are brought to the rulemaking process as opposed to having certainty in statute all the time.
Joe said to keep it to 4 minutes and that's not gonna happen. Daisy has.
I think I'm innocent because I'm just answering questions.
So Leslie brought up a really important factor, and I think it's behavior. And I'm wondering about, behavior of incentivizing people. And would something like this be paired with having insurers incentivize people to sign up by curating benefit packages that would be more desirable to younger or older people? Like, why not just do something like that, regulate that way rather than having people pay a different fee? That's the first question. My second question is, what's the risk if you implement something like this and it does not work the way that you model it?
I think, okay, so first question, I think is a better DIVA question in terms of an insurer question in terms of what activities occur now and what the ACA has bandwidth for in terms of customizing plan design to attract younger insureds. And I would say that does make sense. And I would say do both because we're at a level of, an affordability challenges here that we have to do everything we can. The second question of what could go wrong, is that essentially the question or?
Or what's the risk? What's the risk of implementing something like this? And if it doesn't pan out the way that you expect it to?
I think the risk is if there are big assumptions on the behavior side, that it will prevent people from leaving, or that it will attract people in, that we don't get any optimization out of it. To me, that's gravy, that's icing on the cake. I don't think there's risk in just calibrating how we charge different cohorts of age. I can't think of any at this point. It's possible that some older insureds can absorb 3, 4, 5% increase. It's all of the risks around affordability. Sorry, not all, but some of the risk around affordability is, of course, mitigated by what's left for subsidies, not the enhanced, but the base level subsidies that are available. I think what we're talking about here is that partially subsidized, or now, since the expiration, unsubsidized payer. It's not, who's 300 plus, 400 plus percentage of federal poverty level is now hardly or not getting a subsidy. And how sensitive to price are they going to be? It is not a goal to have older people drop insurance. If that did happen, the pool would survive, in terms of, although it would probably be older healthcare people. People who are going to drop insurance are not folks that need that insurance unless it's truly an affordability thing. And my hope is that we have a system designed. I'm not the right person to talk to because it's between Catamount and the exchange, but that we're not talking about a population that has huge medical needs, can't afford insurance and can't get it in terms of this proposal. I don't believe that's what we're looking at here because of the other safety nets that are out there. I don't know if that answers your question. I don't see it as a risky proposal. I see it as politically risky. I'm here saying we need to raise the rates on some Vermonters to make it more fair and more affordable for another cohort of Vermonters that I think we all agree are having a hard time and I can statistically tell you from tax department data, they make less money.
I'm going to do one last question, Lori, and then we'll move on to the next.
So, do you have the budget today to do the actuarial analysis, or would you be asking for money?
We're not asking for money.
Okay.
So we have some budget today, and we would also rely on the participation of MVP and Blue Cross, the two players on the exchange, to help us design this in an appropriate way.
Okay, and then not that I'm advocating this, but curious if you've looked at the other factors that we don't allow or other factors that other states allow to see if there'd be more of a positive impact for everyone by trying something different.
Have not. And that doesn't mean it's not worthy exploration. I think personally, I believe medical underwriting, I think the ACA disallows it as well, but guaranteed issue, doesn't matter what your health history is. Those are off the table for me. Absolutely. Age, geographic might be something to think about as we have different hospital systems serving different parts of the state with very different cost structures. Yeah. But we did not look at that. Okay. I do want to say, just as an overall, I think that was the final question. So we're looking we would design something 5% upward pressure max. That doesn't mean that's what we're proposing. It might end up being 2%. Whatever we see is a reasonable way that's not disruptive. And I also forgot to introduce that Vermont is one of only 2 states in the entire nation that doesn't do some type of age rating. It is not nationally a radical idea. It's Vermont and New York are the only 2. Most states, I believe, use the full 3-to-1, 300% deviation between highest and lowest payer based on age. So this is very much, honestly, a baby step to try to restore what I think, some equity to who we charge what in the exchange.
We remind ourselves of how many people are in this pool. 70,000.
I believe that's right. Because it would impact small group as well.
Small group and individual, so about 70, we think? That's 70,000.
It's my memory, yeah.
All right. Next,
Next, I
From
think,
age rating, unless you had more to say about
oh, I
it.
have so much more to say, but it's really just answering questions. I think Mary Block should be on screen behind me to talk about some other items in the plan options category. And if it's okay, I'll stay seated right here to give color commentary. Are you there, Mary?
I'm here.
All right.
For the record, Mary Block, Deputy Commissioner of Insurance for the Department of Financial Regulation. And I think it is my pleasure to talk a little bit about AHPs to start. So this is sections 7 and 8 of the bill. AHPs are association health plans. You talked a little bit about this with Jen. We know that there's a lot of small group employers out there that are facing incredible cost challenges when they're trying to provide health benefits and they're looking for options. This is a possible option. There are group plans that can be formed through associations of employers. The one most prominent one in Vermont currently is the Vermont Association, Automobile Dealers Association. So VEDA has an AHP. It's not without, potential concerns, because obviously we're looking to help small group employers, which means those small group employers might move out of the exchange. So that's one of the risks. Currently, under federal law, AHPs are regulated through ERISA as multiple employee welfare arrangements, otherwise referred to as MIWAs. Many acronyms in the federal world. They're required to meet, among other things, the standards of coverage for large group plans. The plan standards are more flexible. They don't require the federal essential health benefits. They provide more options for defining coverage that fit a plan's employees. They still need to meet state mandates. The way they're defined currently under Vermont law, it's defined a lot more restrictively. And we hold them to the small group QHP standards, including full essential health benefits and so forth. The language change in the bill aligns our definition with the federal definitions so that any expansion of AHP types under federal law would also occur under Vermont law when that happened. And we believe the expansion is likely. Some expansion occurred under the first Trump administration. It was reversed during the Biden administration, and we believe it'll again get reversed during the second Trump administration. We would also, after this change went through, have to do a change to our AHP regulations because the regulations actually contain the current benefit restrictions. So we would have to change those from the small group QHP standard to allow them to act as large group as they're allowed to under federal law. And I think I'll stop there and see what everybody has for questions.
Leslie?
So we in Vermont, if I understand this correctly, sort of got rid of association health plans when the exchange came in and whenever that was. And can you help me understand, and you may not know this, why that path was taken? What was the problem with them that they were rescinded? So that bringing them back, does that bring that problem back? I just want to understand that.
So
Yes, it
honestly,
does.
yes. I mean, obviously I wasn't around at the time. I mean, I think one of the reasons that we did it was to support the exchange. So this does run the risk of pulling employers out of the exchange. But we're sort of, desperate times call for desperate measures. And so trying to provide more options is why we put this on the table for discussion.
And it's, I think very clearly the reason for Vermont's historic approach on association health plans, to be clear, is that they do generally pull better risks out of the small group market and leave higher morbidity in the small group market, which raises rates for the small group market, which then means another group says, oh, those rates are high. I think I can do better in an association. So, that trend is not a good trend. I would say combined with age rating, some age rating allowance, which does impact the small group market, there's a hope, and maybe this goes to one of the risks, that mitigates some of that. The overarching thing here is, or the overarching goal here is to recognize we're at a point of cost to small businesses, as I opened with, that I no longer feel comfortable telling them no when they're coming to us and saying, we want to do this. You're not letting us do it. It's better for my business. These are small businesses, your employers less than 100. There are consequences.
Okay, so age rating.
Yeah.
We're trying to stabilize the individual and small group market. We're trying to form more people into it. And then opening up for association, we're then pulling people out of it. And which pulling people out of it raises it in the individual and the small group even more. And if we have the age rating, then that 5% isn't going to be 5% for very long. It's going to be much, much greater because you're pulling out a healthier population, moving them to association plans. And it seems to me that what we are really doing here is we are creating volatility. And it seems as though the last thing we need to be doing right now is introducing volatility into our already struggling market. I mean, these two things seem to be fighting against each other.
They do go in opposite directions. Another way to look at it is, does one mitigate the impact of another? Does the ability to provide the same population that's having good, low claims experience, which could be directly attributed to the age of their employer set, providing them some relief in terms of this age rating proposal, that's going to lessen their attractiveness to form an AHP. Opening up AHPs offers more alternatives. So you're not incorrect. I don't disagree with anything you said. They do run in opposite directions in terms of the small group market. They don't have to happen together. We're not saying you have to pass both in terms of this to work. I'm saying we have to be sensitive to what we're hearing from the business community, that they understand the impact, and maybe there are other ways to work. There are other ways to work on the health of the small group risk pool, age rating.
You were talking about fairness with, and I guess insurance costs so much because our prices are high.
Yeah.
Bottom line. I mean, that's a million other reasons, but we pay this much for insurance because our prices are high. This doesn't do anything to influence.
We'll get to that part.
Okay.
We have 3 pillars here. Cost containment is going to be this afternoon.
It's just shifting who's paying.
But that's important because remember, across the border is New Hampshire that has full age rating. And there are many businesses that can set up shop in New Hampshire instead of on the Vermont border. And whether they're in a small group market or individuals and where they live, it does make a difference, right? So within Vermont, you're right. We got to tackle cost of care.
They also have a lot more population.
They have more population, they have bigger risk pool, they probably have better competition and access.
Lower prices.
Yep. But in addition to that, all those things being equal or not being equal, if you're 25 years old, you want to live in New Hampshire in terms of if the only thing on your mind, which is never the only thing on a 25-year-old's mind, but in terms of, we're not just shifting things around, there is an interstate impact to this that we have to recognize.
I'm 25, I'm still on my parents' insurance. Lori.
I was gonna say, just one second. The other thing to consider is small group employers don't have to offer benefits. So if the option is the exchange or nothing, they may decide to stop offering benefits. If the option is the exchange and AHP or nothing, maybe they can transition to an AHP and be able to continue to offer benefits to their employees. So it's just another pathway to hopefully keep them from dropping out of the market.
Right. Has any analysis been done on the AHPs and how we would expect it to change? And do we have any data to do that analysis?
That's very behavioral, I think. Mary, do you have any thoughts on that question?
I don't know that we do because there's a lot of ways an association can form. It's a little more limited right now until the federal law changes, but it's hard to say, and it's also up to the individual employers to decide to join the association. So I'm not sure we have the ability or the data to do any predictions there, unfortunately.
So I partial answer that question. I'm on a board of a nonprofit that looked at a similar type self-insured model. Volatility was one reason that we didn't pursue that.
Yeah.
It was more ERISA than AHP, but I think the same decision applies, that the cost savings were kind of there, but not enough to and that's a decision that's made 1,000 times over.
Yeah.
So it's really hard to predict that, but I think it is absolutely fair to say that when you loosen AHP rules, you will see healthier risks leave. Yeah.
I would think that the cost also would be influenced by who the TPA is.
Yeah.
What is TPA?
Third party administrator. So basically the contracts that, a Cigna has with Vermont providers is drastically different than maybe even Blue Cross Blue Shield has of Vermont, which also increases volatility into our provider space. Not getting the commercial rates that when you start pulling people out of the QHP market. It's just all that stuff to think about. Lots of things to think about.
Yes.
Yeah. I'm gonna go Karen and then Wendy.
What I hear from my constituents, small businesses and the nonprofit sector is they do want to offer health insurance. And in the nonprofit sector, as you were just describing, that what they have to spend on health insurance now takes away from their mission directly. And so some of them have opted to do self-insurance. And some haven't, but when you remember just talking about people that are 65 and under, correct? Because we have Medicare, Medicaid.
Yeah.
So we're already starting with a pretty small. Then we have the state employees, and they're off to the side with their own self-insurance pool. And then we have teachers, and they're off to the side with their own self-insurance pool. And we have some smaller organizations that are doing it. So we're pretty soon, who's left. And then one, I don't know, incremental question I have is in the nonprofit sector, when health insurance is offered, the subsidies do not go along with that, even if one might qualify generally. Do you know anything
Can
about
you
that?
repeat that, or unless Mary heard that correctly?
Yeah, so if you're working for a nonprofit and,
Right.
and your employer offers you insurance,
Right.
no,
No,
you're not eligible for the subsidy.
correct.
So anyways, there's just a lot of pressure for them not
Okay.
insured. And this age separation would only be between age 26 and 65, right? Do I have that right? I mean, when you start parceling out age delineation.
It could be lower than 26. Now, you can be covered on your parents' plan up to 26, but yeah.
So I don't know, that I'm just
Yeah.
trying to sort out, we all want
I think
costs
that,
to go down and premiums to go down. but-
yeah, I absolutely agree with the chair. The solution to all of this has to be cost of care. And we have a separate category in 585 that addresses that, at least from an insurance and insurance regulation point of view. That is the only real meaningful progress we can make. Everything else is just important, I think important adjustments. But another thing I want to respond to is you're right. Public employees, teachers, and, have availed themselves of a self-insurance model. And so that's something we all have to think about when we say certain employers may not.
And
through
thinking
an
about
age.
fairness and equity,
Right.
everyone. Okay.
Oh, thank you. All right, this is Wendy.
This just feels like the ACA is just dying by 1,000 cuts to me. It just makes me sad that, but that being said, well, has Viva weighed in on this? Like, this would be a whole system change for Viva. I mean, because subsidies are done in a computer and, you know, workers just inputting this kind of stuff. So now there's gonna be these incremental cutoffs that's gonna increase the amount of subsidies that somebody gets. And I know I could word subsidies, but it just seems like a lot of money and time and effort is gonna go into actually doing this. What's the cost now, this or that?
To be honest, we haven't done a cost analysis with Viva on, and I hope I'm not confusing the word subsidy. When we talk about subsidy and age rating, it's kind of the inherent overpayment a younger cohort is making because of the claims experience of an older cohort. Versus this doesn't change federal subsidies. In terms of ACA death by 1,000 cuts, we had an individual mandate. That made community rating make a lot.
Right, yes.
That made community rating make a lot more sense. If you can basically say you have to be insured. We had a younger population, age rating or no age rating made a lot more sense. So you're right, losing those things, which, you know, I don't think we have control of. Well, I guess you could pass a statewide individual mandate, but that's not our proposal, I think. I don't know. But yeah, it's, I think my position on this is guided by the fact that if we look at the trajectory in our rearview mirror of healthcare costs and healthcare policy, it's not something we can sustain and continue. We have to do some things differently. Some of them are harder to swallow than others.
Growing the pool be more effective? Getting more people into the pool?
That would make the pool more stable. If they are healthier people, yes, it would make their rates go up and the joining rates go down relatively.
I mean, it just seems like what we've seen over the past few years is that the pool, QHP pool is shrinking. Employers are leaving because it's easy for them to become self-insured now, which is expanding the self-insured market, which is further destabilizing the QHP market. And the pool is shrinking, which is raising costs. And, you know, the really sad part of it is that the QHP market is so unaffordable at this point because it is the only market where we can sustain our hospitals and our providers, and they're taking on that cost shift and that burden because we have no regulation whatsoever over the self-insured ERISA market. And I mean, it seems to me that what we want to be doing is we want to do everything we possibly can to grow the QHP market, and that will stabilize it. And that will create affordability. Well, that and prices, but we're not in that section yet. I think I'm gonna, okay, somebody else have a question. Oh, Brian.
I had some, I was on Zoom and I was holding them in the whole time, so. It's not.
We are running dramatically behind also,
Okay.
just to let everybody.
So make it snappy. All right, so I heard you mention wanting to expand choice, do different kinds of rating. You mentioned age rating, you mentioned geographic variations. Are there additional,
That's not in our proposal. That was in response to.
you mentioned it as another possibility.
Yes.
Yeah.
Not one we're pursuing.
Are there possibilities for rating based on income? I know we currently subsidize costs, but why is it that a person who makes $50,000 or maybe not 50,000, 60,000 pays the same as someone who makes $600,000, yet they make 10 times more income? Like, why aren't they paying 10 times more of a premium if they can afford it?
Because we don't have that structure in place. I would say that part of the value proposition of moderate age rating is that there's a direct correlation between age and income, so it better aligns income and thus affordability with health insurance premiums. But income-based health insurance premiums aside from subsidies is not something we have or that we're proposing.
Is it allowed?
Allowed?
The CACA?
I do not think it is forbidden for a state to come, I mean, I think it's probably actually possibly problematic actually to charge a non-actuarially supported rate that's meant for income redistribution, I would guess. But of course, a state could come up with different ways to subsidize or charge higher income earners, and it's discussed all the time in Ways and Means.
Can you bring us, at some point, bring us some data to show the correlation between age and income in Vermont? Because you asserted that generally people who are older are making more than people who are younger.
Yeah.
Can you bring us some evidence and demographic data to show? Okay.
I'll put that into the record. I have an analysis from the tax department on both individual and joint filers' average income by age.
Thanks. And then the other question, I'll merge them into one, no pun intended, but I'll merge my questions. So if we're trying to increase options for people and choice, like I'm hearing age rating increases choice because it reduces premiums on the exchange for younger people, providing an incentive for them to choose that versus being uninsured. And then the other choice that you're promoting is association health plans being allowed. Are options on the table perhaps a public option? Like could adding a public option to the mix on the exchange give people more choice, and how might that impact rates of insurance? And also, is another possible option merging with another state? Is that allowed under the Affordable Care Act? Could we potentially work with New Hampshire, for example, or New York State, Massachusetts, or could they all combine to create a bigger market?
We've talked about the multi-state option. Our cost structure is so high in delivery of care in Vermont, it seems dead on arrival in terms of asking them to work with us in terms of the cost of care in Vermont. In terms of a public option, I'm not sure what that would look like or what it would take. Or, I would say that the QHP and the regulation around that, and the fact that unfortunately it has become somewhat of an insurer of last resort or an option of last resort, starts to look like a public option. But, public option also has 5 different definitions if you talk to 5 different people.
Yeah, I think I was referring specifically to allowing people to buy into the state Medicaid program, as like letting people purchase Medicaid as an option, so that we're giving people a third choice on the exchange.
Yeah, that might be a question for DIVA or AHS.
Yeah, he's not answering. He's asked Eva that one.
Well, I think I've shared with this committee, I am not a healthcare policy expert. I really am not. I'm more of a financial person.
Did I have any other questions before we, but just to Mary and Kaya, you're done with yours.
There's one more, isn't there, Mary? Is there short-term limited duration? Did we cover that?
Oh, we haven't covered that.
Yes, we have short-term limited duration.
This, age, the concept. May I?
Yes.
It'll be quick. If I understand this right, there's this tension between age rating and the association plan is there any analysis that's been done on the impact of one versus the other? So if we were thinking about that tension, where we wanted to lean?
I think because again, it's very behavioral and a little easier to predict and potential to predict on the individual market or on the individual decisions for the exchange. But for businesses making that decision, it's, I think, a lot harder to predict. An important fact that I think Mary did mention, though, is that the ability to open up more businesses to form association health plans at this point is more throttled by federal rule than anything we're proposing here. So federal rule would have to change to allow, I forget the term, but non-affiliated or what, non-conforming, something like that, groups to form an AHP. That is something we can't change. So that's changed it. So the impact of what's in here for AHP reforms is varies by what the feds do.
So it's dependent on federal rule. That's what, and is there any?
Some of it, not all of it.
Is that likelihood of happening?
Um,
Never mind.
And it has to be an existing association?
So the other part, Mary, you want to cover the kind of two components of the AHP proposal, the federal reliant and the non-federal reliant?
Yeah, so by changing we would be changing our statute to align with the federal definition of AHP. Right now, the federal definition of AHP is throttled back because the Biden administration pulled back from what the first Trump administration did. It's likely that the second Trump administration will probably go back the other way again and open it back up and allow more flexibility for the types of associations that could be eligible. The second piece that we have to do, regardless, is to change our regulations because the benefit structure is in our regulations. And right now, unlike the federal law, we limit or require that AHPs offer the same benefits as the individual and small group markets. So we have that requirement. On the federal level, they align with the large group market because if you think about it, right, it's an association that is creating a large group in order for them to allow them to have that flexibility and those options that are available for a large group. So we would have to do both. We would have to change so that if the federal law loosens up the kinds of associations that could form and take advantage of this, and then we'd have to also change the regulations to change the benefit structure so that it aligns with large group.
So can I just clarify? I'm sorry. So if we change this, let's say we move forward with this, nothing actually changes unless the feds change their policy? I guess I'm confused. I just got confused by that, or rule, whatever.
So if we make changes to this and then change the regulation, it would impact existing AHPs,
Okay,
right? They would have that large group market flexibility.
okay.
But there would be very little movement as far as the types of new AHPs that could be formed because the federal law hadn't expanded.
Okay, thank you.
Clear as mud.
Yeah.
Always is. Just
Limited
Yes.
duration.
Very hard.
Short-term limited duration plans. Mary, I'm going to attempt to do this quickly. We've shut the door here in Vermont on that. Short-term limited duration plans are not comprehensive major medical. As regulators, we do not want people to think that they are a substitute for health insurance. They are not, in terms of range of benefits. They do not follow the same rules as a comprehensive major medical plan. That can be surprising to consumers. So the regulatory approach up until this proposal has been no, essentially. Doesn't say no, but we've put so many restrictions on them that we don't have any filers in Vermont.
It's an example of what one of these are, because I don't think we've ever.
So these
I'll
are-
leave-
I was gonna
Go
say,
ahead.
these are short-term, meaning they're usually 3-month policies that are, if everybody is using them appropriately, used as stopgap policies. So somebody's in between jobs, for example, and they need coverage because they've got this gap. You could buy a 3-month short-term limited duration plan to sort of, in case you have a catastrophic issue that happens during that gap. They can be abused, right? They can be packaged with other policies to make it look like you're getting comprehensive coverage, which is why we've always been very uncomfortable with them. But they are used in other states to sort of fill that gap, and to help people who are just need something. So this would, we restricted them so much, and the reason that nobody wants to write them is we require them to have QHP benefits in them. So nobody's going to write a 3-month QHP policy. And so this change would take the benefit restrictions off, and would allow you to stack renewals. So we would do 3 month, you could do 3 month policies with essentially 4 renewals so that you could go for a full 12 months with these stopgap policies. In the first, this is another federal law thing, right? Right now, the federal law wouldn't allow for that. So we would be changing this in anticipation of a change. The first Trump administration, there was a change that opened this up. The Biden administration pulled it back again. And the Trump administration has already said that they're interested in changing this again, and that they have issued a letter of non-enforcement of the current policy, basically. So.
And the purpose here is to understand or to, and keep in mind that any new carrier that would come in would have their policies reviewed by DFR and their rates reviewed by DFR. And we can deny those. We can, they're not conforming. So we have a protection, what appears on the market, even with these changes. But this really comes from a concern that we have, as we discussed at the opening, thousands of new uninsured Vermonters with a direct correlation to the expiration of the tax credits. So I find ourselves in a question, or in a position to say, do we really want to not offer some options? Not the best option. It's not a Cadillac. It's not even a Chevy. It's a bicycle. Do we let people buy bicycles? Right now, we don't let people buy bicycles. Just don't move.
Yeah, if they're gonna drive on the highway, then you don't want them to have bicycles.
It's a fair way to take that analogy.
Yeah.
Motorcycles though, they have motorcycles.
I see you, Val. I just have clarifying question. So this would allow like a 3-month policy and then a renewal for up to a year. Could the
Yep.
person then drop it for 3 months and then start all over again? Is there a limit to, I mean, this is like living in Europe.
Yeah.
Yeah.
We could put a limit on it. I'm not sure there's a limit currently the way it's written. I know in the original Trump expansion, it was 12 months in a 36-month period in the original version.
Okay.
So.
Okay, Val?
I know this, the only folks I can think about this being incredibly helpful for and like worth the risk of abuse really is are folks in the military. When they're not deployed, they don't have health insurance. I've had a couple constituents come to me about this, or maybe it's folks in the reserves or something.
They're not on active duty.
Yes, if they're not on active duty.
Interesting.
So when we're thinking about creating short-term limitations, we should carve out an exception for those folks.
I thought you purchased right there during your inactive status. I'm sorry, I'm not. We should have somebody who actually knows what
Yeah.
you're talking about.
Yeah.
I mean, this is another area that will be bound by federal law. So right now, we'd be making a change that wouldn't change because federal law right now is 3 months, but no more than 4 months, which is a little strange. Because you couldn't even do a full renewal. But if the Trump administration opened it up, then we'd again be able to move beyond that.
In addition, Mary, to removing our requirement that they have to have essential health benefits.
Yes. Yeah. So we would need to make regulatory changes also.
That does
And
not,
as a part of those regulatory changes, we can obviously build in protections and things like that to make sure, hopefully, that people don't get confused.
Make a comment, just.
No. I'm wondering if we can discuss a scheduling thing here real quickly, because we are clearly engrossed in this.
Yeah.
We have you pretty much all day today. And I was wondering if we could take a break now. We could get to our next witnesses on these 3 sections. And then maybe start what we were intending to start at 10:45, but will not be. And then move the efficient service delivery into the afternoon. And then we can get rescheduled on insurance government governance and executive compensation. Although we actually have time this afternoon, I think. Is that okay?
Right?
Can we take a break right now? Okay.
Yes, may we?
Yes.
Shall we?
So we're amending our schedule a little bit, but same people.
Different topics.
Different topic. Okay, so let's take a break.